However, I'll take you through the overall overview of what is CPHQ as well. If you can just answer these questions, maybe for 2-3 questions, poll questions. So have you undergone any formal quality training? So 75% of you are telling no. Okay, fine. That's good to know. That means I'll be starting from ground zero, as majority of you have not undergone any formal quality training. So thanks for participating in the poll. And maybe 2 or 3 more questions, if you can just answer. What is your role in the organization? So I see around 25% of the people say they are nurses, and 25% say physicians, QA, QC 14%, lab 7%, and pharmacy 11%, and remaining 15%. Okay. Thank you. Thanks a lot for participating in the poll. And now maybe one last question. Were you aware of CPHQ before you heard from us? That means, so maximum people are telling yes. Okay, you are aware of it. So you are pretty serious, yes, and you know what is CPHQ. So I'll not spend too much time on telling what is CPHQ, but briefly, maybe 2-3 minutes, I'll very briefly tell you what exactly it is. Although the video which was repeated 2 times, because we are waiting for people to join in. So it mentioned what is CPHQ, but yeah, okay, sorry. And fine, so thanks a lot, and let me take you through the agenda. So we'll discuss what is CPHQ, and then I'll introduce you to the different modules of CPHQ. Then we'll talk about healthcare data analytics, and that is the topic of the day. I keep taking these training sessions, which are totally free of cost, and at every time we take sometimes leadership module, sometimes process excellence module, sometimes data analytics. And data analytics, why it is more popular, because most of the people who attempt the CPHQ exam and fail, they fail in the data analytics part. So that is why I thought maybe I'll talk about data analytics. I'll show you some projects from hospitals if time permits. Even I'll talk about process excellence initiatives, which are very much part of your CPHQ trainings. And towards the end, if we have time, then we will have some discussions as well. Let me formally welcome everyone with the video. Has been consulting and training the professionals in the organizations around the world since 2006, and we have trained more than 150,000 people and consulted for more than 500 organizations, which includes Fortune 100 organizations too. I'm Amitabh Saxena, and I have designed this program based on my 30 years of experience while working in various industries across many domains. The whole Anexas team once again joins me in welcoming you. So thank you, Masilda. And Krishna is telling that voice is not audible. I hope I'm audible, Dr. Harsh.
Can you be a bit louder, sir?
Oh, okay. Maybe, okay. Okay, now, is it okay?
Yeah, a little better, sir.
Yeah, I think actually today I have joined from my mobile as well as the laptop. So that probably that is the issue.
Maybe you can bring the mic a little closer. So
Okay. Okay, one more thing. Let me attempt something else. Um, just give me 1 minute. How is it now? Is it better?
No, sir. Earlier was better.
Earlier was. So no worries. Yeah, so I've gone back to the there are 3, 4 mics. Okay, great. So once again, welcome, formal welcome to the training program. Now let me take you through the organization, and organization is existing for the last 17 years, and we have been conducting training programs around the world, almost all continents covered. 150,000 people trained and certified in quality domains. Just to prove that I have done training programs worldwide, these are some programs: London, Mumbai, Riyadh, Jeddah, Dammam, China, Japan, and Switzerland, and whatnot. Many hospitals, many other organizations also apart from hospitals, and almost around the world. So I think just to prove that we have conducted training programs worldwide. I've also been a speaker for the last 10 years consistently in the Hospital Management Asia conferences. 5 times I've been a keynote speaker as well. And we have done a national healthcare service in UK. They are also our clients. We have implemented quality initiatives, Lean, Six Sigma, and other initiatives in Ministry of Health in Saudi Arabia, in UAE, in Qatar, in India. And here is just a brief description of. Just let me know if the video is visible, audible.
No, sir. We can't hear it.
Is the video audible? Just give me 1 minute. I think I will just switch on my volume. So I hope the video is audible.
Well, we have Alex with us.
Yes, sir.
Excellent Lean and Six Sigma projects in national healthcare.
So we are not able to hear.
So you're not able to hear the video, is it?
Yes, sir.
Oh. I think let me once again play the video.
Alex with us, and he has done excellent Lean and Six Sigma projects in national healthcare service and in hospitals. So, Alex, you'd like to tell us something about it?
Hello, I'm Alex Wells, Head of Service Improvements at the Royal Liverpool University Hospital. I've been really fortunate to present today on how us as a trust are using Lean and Six Sigma principles to deliver better care for our patients. I presented today on a lot of the work that we've done around how we've improved patient outcomes, reducing mortality, improving length of stay, and also talked about how we can actually realise some financial benefits from that. Over the past 2 years, we've been really fortunate that we've done some good work, and it's actually delivered us £2 million worth of quality efficiencies through delivering better patient care.
So I think just to tell you that, we have implemented Lean Six Sigma in various hospitals, quality improvement initiatives. So we have got many videos, including TV programs, and those who are from India, they can recognize this gentleman. Then Z Business Show, we have 13 episodes on quality excellence and process excellence, and uh, American Society of Quality also spoken. We have got Dr. Tarif Alama and Dr. Muhammad Abdul Ali from Ministry of Health. Dr. Tarif Alama is Deputy Health Minister of Saudi Arabia, and many more people from Ministry of Health who have attended our training program. So just to tell you that we have been doing quite a good job in the industry, and this was just to prove our credentials. Okay, so what is CPHQ? CPHQ, very, very quickly, most of you are already aware of, so I'll not spend too much time on it. The National Association of Healthcare Quality, it issues the certificate, and you have to pass the examination. And if you earn a CPHQ, you are going to get a better job, and also you are qualified to improve any process in the healthcare industry. Around 125 questions are there, and out of that 15 are pre-test questions which are not scored, and I talked about it in the previous video which I played in the beginning. So now I'll just move on to the learning part, and let me tell you that what are the different modules of CPHQ examination. The first one is quality leadership and integration, and we have got 19 questions in it. It talks about strategic planning and stakeholder engagement. Strategic planning means as a quality leader, you have to assist the leadership in planning on creating strategies so that you can embed the quality culture in the hospital or your lab or any institute where you are from. Stakeholder engagement. Whenever you are trying to create a quality culture in the organization, usually you will do improvement projects, you will establish KPIs. And when you are doing this, you have to engage the stakeholders. And who is a stakeholder? Any person who's positively or negatively impacted by your initiative. So any stakeholder, all the stakeholders actually should be engaged. Otherwise, they will not support you as you do your projects, improvement projects, or in your initiatives, in your efforts of bringing in quality culture in your hospital or a clinic. Definitely, you need stakeholder engagement. So how to do that? That is dealt with in this module. Then in the performance and process improvement, there are 27 questions, and here you learn about different process improvement techniques, methodologies, Lean, PDSA, Six Sigma, and you also learn tools and techniques like fishbone diagram, FMEA. And if time permits, I'll talk even about FMEA today. And then participating in the monitoring of project timelines. And the best way to improve anything, the best way to improve your processes, your clinic, your hospital, is to take up improvement projects. And what is the definition of an improvement project? Or definition of a project? A project has a starting point and an end point. It doesn't exist after some time. So whatever you want to improve in your organization, you can translate that improvement opportunity into a project. I will show you one example of a project, or as we learn the different tools and techniques in data analytics, today we will try to do a project. Okay, I'll be analyzing the data very quickly because we don't have time to explain each and every tool, but I would like to show you all the tools and techniques which a CPHQ is supposed to know. And this will help you to understand overall data analytics part of CPHQ curriculum. So this is about performance and improvement. And then we also have the third one, population health and care transitions. Then another one, which of course today I'm going to talk in detail about healthcare data analytics. Here you learn the basics of data analytics, basic statistics, mean, median, mode, standard deviation, normal distribution, control charts, different types of control charts, and then different ways of interpreting the data. Whatever data you have collected, you would like to present the data to the management and to also the ministry at times, so that it can be easily understood. So how to communicate with the data, all that things are coming. All these things are coming in data management systems and measurement and analysis. Then we have got patient safety module, and which carries 18 questions. So if you see carefully, the data analytics carries 26 items. So which is the maximum weightage in your exam. So I'll talk about today about this topic. Of course, in brief, in 2 hours, we can't talk too much. Then quality review and accountability is the sixth topic, and regulatory and accreditation. How to prepare your organization for healthcare accreditation. What are the different types of healthcare accreditation? All these things are covered in the regulatory and accreditation topics. We have been conducting these training programs for the last 12 years. And as I told you earlier in the video, those who joined earlier, I told that more than 1,000 people, the floating population of the CPHQ certified professional is 17,000. 17,000 means on an average, like every 3 years you have to renew. Some people don't renew it. So on an average, around 16 to 17,000, always there's the floating population of CPHQ certified professionals. And we are happy to contribute that till date, 1,000 professionals from our institute have got the accreditation, which is one of the highest. I don't have the data of other institutes, but let me tell you, for the last 10 years, we are very well known for our quality trainings. And once again, welcome to the training program. Now, let us directly jump to the data analytics part. So when you are talking about the data analytics, in fact, earlier, I'll skip the quality leadership part today. So as I promised that, let us learn into the deep dive into the data analytics directly. If time permits, I'll talk about the different wastes, Lean and Six Sigma as well. Okay. How many of you are aware of Lean? So before I enter into the data, let me talk a little bit about Lean as well. Lean as an initiative to reduce wastage in our hospital. Okay. So let me talk a little bit about it. Anyone is aware of Lean? What do you mean by Lean? Just let me know. So typical hospital environment, you have got high volume, then you have got high variation in the number of patients, variation in the processes, variation in the services, and then it requires high speed, which of course involves a lot of stress. High turnover, highly regulated. It leads to multiple problems like service breakdowns, wasteful processes, and medical errors. So let's talk about first wasteful processes. Wasteful processes, how you can reduce them. So please understand, in the Lean, any process step is a waste if it is not done right the first time. If the customer, in this case, it could be the patient or the Ministry of Health, is not willing to pay for that step, and if that step is not bringing the input closer to the output. Now, these are certain jargons I just used. Let us first understand, to understand the quality, always better to understand always better to have a systems thinking approach. So what do we mean by systems thinking? Systems thinking means we view our organization as a system. We view our organization as a system, and This approach was given by Dr. Deming. So let me briefly talk about systems approach first, so that you can understand the fundamentals from where process excellence is coming from. Think of your organization, and I'm drawing a model of almost all the organizations of the world. Think of your hospital or a clinic or a lab. You have got certain inputs. Yeah. The inputs are processed through step A, B, C, and D. And then you have got outputs. So if you are a lab, so you take the inputs, maybe let's say I'm talking about blood sample. Then you have got reagents, etc., the registration information of the patients, and then through multiple steps, finally the output is the lab result. Okay. And every organizations have got multiple processes, similar to what I have described here. So you have inputs through a series of process steps. This is a process, A, B, C, D is a process, and A and B and C and D are the process steps. These outputs are either in the form of service or sometimes in the form of a product. Service or a product. Service, a product, or a capability to provide service. It could be third one also. A capability to provide service. So that is the output of every organization. So if you are treating the patients, the patient treatment is the output, right? If you are discharging the patient, the process of discharging a patient, if I'm talking about discharging a patient, then in the get output is the discharge of the patients. Now these outputs are given to the customers. Customers could be patients, customers could be relatives of the patients, customers could be Ministry of Health also. Now inputs are coming from the suppliers. Suppliers could be the patient sometimes, he or she is supplying the information. That information is a key input of our treatment process. So you have suppliers. And the customers will either give feedback. Sometimes you have to be proactive enough to seek the feedback of the customer. Or you can predict the demand of your services from the customers. And based on that, you have to make your strategic plans. So here's strategic planning. Or the senior management will create strategies. And based on the feedback which you are receiving from your customers, the strategy team may inform the different departments to change the standard operating procedures or the way of working or providing the service to the patients or the customers. They will also inform the suppliers to supply the relevant inputs so that they can be processed to produce the output. Now, this is a typical systems map, also known as value stream map. This is known as value stream map. So try to fit your organization into this map. And I hope you are able to see that. I hope you are able to see your department. See, systems map or value stream map could be done for a department also. Systems map could, or value stream map can be done for an individual also. You can create your individual value stream map as an individual, how you are adding value to your customers. Your customers could be your boss, your organization, sometimes your family as well, etc. So this value stream map can be done for a person or a department or the whole organization. And this tells us that there are interrelated components of the system. So the leaders, especially the quality leaders, have to have a systems approach. Okay. And as long as there is a flow in the system, continuously suppliers are providing the input and we are providing the services, and the outputs or services are given to the customers is deriving benefits out of it, value out of it, and then based on that value and the feedback, we are making our plans and changing our strategic plans. If we are doing this, then the system is healthy. But suppose there is interruption, means A is fast, B is slow, then you will see a lot of waiting time here. There's a queue in front of B. Or C is committing mistakes. These errors or mistakes will pass on to D. And then it will get passed on to the service or your product. And of course, the customer will be then in that case unhappy. So these are the signs of unhealthy system. And CPHQ professional is the doctor of the process, doctor of the system. So you get tools and techniques to treat the system of all the errors, all the delays, patient dissatisfaction, cost overruns, and wasteful processes. And that is the main job of a certified professional in healthcare quality. When you attend our training program, you don't know, of course, we prepare you for the CPHQ. And we also give you a CHQ certificate as well, certified healthcare quality expert. And that is by attending the session and passing some exam. Really, just by attending the session and learning those tools and techniques, we also provide you an attendance certificate, which is certified healthcare quality expert. But to get the CPHQ certificate, you have to appear for NAHQ's exam. You have to get registered there and you have to pass that exam. And as I told you earlier, our lot of our professionals have passed the exam and our passing percentage is quite high. Okay. In fact, in the last 6 months, whoever appeared for the exam, they passed. So in general, we have got let's say in a batch, we have 20 people. Some people just say, I'm just attending to gain knowledge and I'm not interested in appearing for CPHQ examination. And some people want to appear for the CPHQ. Generally 50-50 ratio it is. So out of those 20 who attend our sessions, 10 of them are interested in passing the CPHQ examination. And whoever has appeared for the examination in the last 6 months, all of them have passed. And if you are on LinkedIn and you are linked to me, or you're you have liked our page, or if you're following Anexas, your page in LinkedIn or Facebook or Instagram, you would have noticed once the results are announced, we publish the news about the CPHQ professionals who passed the examination and who were trained by us. So there is a huge list. Okay, good. Any questions on systems map? Any questions? Okay, great. Now let us minimal show is raising the hands. Can you write in the chat box? If you can write in the chat box, if you have any question, you can write in the chat box. Okay, great. Now let us move ahead. So let us talk a little bit about lean part. What is lean? Okay, so minimal is telling, okay, nice to meet you again. Okay, thank you. Thanks a lot. Okay, it is nice to meet you again as well. I think you have attended our previous training programs, maybe Lean, Six Sigma, or uh, artificial intelligence, data science, etc. I conduct AI trainings, data science trainings. By the way, I strongly recommend you watch my 2 hour video, which I had one presentation I had made for a very reputed hospital. Uh, in international medical center, I had made it. That video of AI and data science in healthcare. Now, it is not related to CPHQ, by the way, but every professional should know the basics of AI and data science for healthcare. So please watch this program. Please store this link, and strongly recommend that. I strongly recommend that please watch this 2 hour presentation. You'll get to know a lot of things which are happening nowadays in the world of. And I've started from ground zero. I've assumed that you don't know anything about AI, you don't know about anything about data science, and I've explained everything from ground zero. And even I have introduced you to something called as Python as well in that training program. So please, please, please watch that program. So I think here Naveen has put the link of that program. Whenever you get time, tomorrow, I think there's a weekend, please go through that program, go through the video. Okay, coming back, there are 7 types of wastes in our processes. Waste of intelligence, waste of rework, waste of waiting, waste of inventory, waste of motion, waste of transportation, waste of overproduction, and overprocessing. Let us take some examples. So these wastes are actually hidden wastes. They are in our systems, they are in our processes, but they are not visible to us. Okay. Overpricing, overtime, overstaffing, insurance, reimbursement, everything. If I take a simple example, if you look at this, walking to the outpatient department, the first step actually takes 4 minutes. Similarly, all the steps are mentioned. And you will be surprised to know that whatever steps we follow to provide a service to our customer, and think of that model. And I'm now going to talk in terms of jargons. So you have inputs, you have processes, you have outputs, and you have customers. So whatever service we are providing or output which we are providing to our customers, it passes through many steps. And 80% of those steps are non-value added steps. 80% of your steps are non-value added steps. Like walking to the lab, registration in OPD, it is not adding any value. Why? Because customer is not willing to pay for it. I am there to, what is the value we are looking at? Okay, what is the value we are looking at? Think of the value. See, what is value? Whenever we are serving a customer is looking for some value. And this value, sometimes we miss out. Say, for example, right now in this training program, you are looking for a value. Now, what is the value you are looking for? Maybe knowledge about the CPHQ tools and techniques, knowledge about the CPHQ exam or exam preparation. And, or in general, I would say download of information, process improvement related information from my brain to your brain. That is the value you are looking at. Now, to provide that value, if I tell you, well, I will travel to your city, the traveling or transportation is not going to add any value to you. Or I will book a nice hotel and I stay there. Booking the hotel and staying there is not adding any value to you. I take a taxi to come to your hospital. It is non-value added activity. What is value add? Is the knowledge or the transfer of knowledge. So please understand, when we talk in terms of value, we have to talk from customer's perspective. If the customer is not willing to pay for it, it is non-value added steps. Just wanted to inform you. And then you will not be surprised that in most of our processes, whatever we do in our day-to-day life, 70 to 80% of our time is waste, is actually belongs to wasteful steps. We call in Japanese as muda. So only 2 steps are value added here. What was the value here? Value was, I want to know the health status. The patient wants to know the status of their health. That is the value. Now, if you tell them write a name and fill in a form, they are all non-value-added activities, surprisingly. Some of you might be surprised, but that's the fact. When you consider these steps as non-value-added activities, you will try to reduce them. There is another waste called waste of intelligence. What does it mean? To give an example, 80% of the nurse calls from inpatients are housekeeping in nature. Means my pillow cover is dirty, my bed sheet is dirty. These are all housekeeping related calls. The nurses are not here to take care of the bed sheets and the pillow covers. So if you involve them in that, then they will forget to give the medicine. This is waste of intelligence of the nurse. Or a surgeon is waiting for the surgery to be performed because the operation theater is getting ready. That is again example of waste of intelligence or the talent of the surgeon. So there are many examples. I'll not talk too much about it because today, as I promised, I'll be talking more about the data analytics. So I just wanted to take you through some of the case studies towards the end. And to understand those case studies, you have to understand some basic statistics. And I'll be starting with basic statistics after 5 to 10 minutes. But before that, I was introducing to lean. So we doubled the cardiology lab capacity from 8 to 16 by removing the unnecessary waiting times. Earlier, the cardiology program was adding 2 more cardiologists, and the outpatient cardiac diagnostic lab had a capacity of only 8 exams per day. And now, after redesigning the work without adding staff or buying new technology, in a single day, capacity was doubled to accommodate 16 exams. Earlier, in one hospital, patients had to wait up to 6 days between the cardiologist exam conducted in the doctor's office and the treadmill exam conducted in the diagnostics lab. So after observing the flow of the patients from the cardiologist office to the diagnostic lab, 2 physicians decided to see the patients in the diagnostic lab. And patients make now appointment to see the diagnostic, to see the cardiologist there. And the daily schedule for diagnostic exams was changed so patients could get both exams the same day. So now we are making our process keeping in mind the customers, and not to keeping in mind our convenience. So that's very, very important. So similarly, there are many exams. In one of the processes, the number of approvals were reduced, number of signatures. Approval is not adding any value. You may be again surprised to know that approval is not adding any value. So try to reduce the number of approvals as much as possible. Is it really required? Many of our approvals are not required at all in the current scenario. We are just following 10-year-old steps, 20-year-old steps, maybe 30-year-old process, which was designed 30 years ago. It is still being followed despite understanding or knowing that there is a lot of new technology available. Despite having the technology, we still keep following the old processes. So try to eliminate the waste as much as possible to create the value. This is a typical patient flow in a hospital. I'm not going to describe that. Everyone knows about it, but just wanted to tell you that some examples of waste may include unnecessary process, motion, unnecessary waiting, unnecessary transportation, errors, defects, unnecessary stocks of production. These are all examples of waste in our systems. A person who's not utilized fully is a waste. An equipment which is not utilized fully, like you have got robotic surgery equipment lying there, but no one is using it, it is a waste. In a lighter vein, I can say that cost of a 5-minute MD walk is around $6.30. So sorry, $6.30. Walk to elevator 1 minute, elevator wait 3 minutes, elevator travel 1 minute, walk to lab pharmacy 1 minute, nurse cost per hour $50, cost of 1 trip is $5, cost of 5 trips per day per nurse is $25. And imagine if there are 200 nurses in a large hospital, multiplied by 365 days, it will run into millions of dollars. Okay, simple things. translating into big money. Lab and pharmacy on second floor, radiation equipment on ground floor. Bring them together on same floor and you can reduce transportation waste. Waiting time, during the telephonic conversation, interruption is a waste. So I'll just, it's a vast topic, but today's focus, as we mentioned earlier, was data analytics. So I'll directly jump to the data analytics part, and that part I will be taking a little slowly. Okay, and today is more like introductory program. I'm just introducing you to one of the topics, but we have full-fledged 5 days CPHQ training sessions, which we have been running for the last 12 years. And those who are interested, they can always join us. Yeah, so one of the ways to reduce our errors is visual controls. So some key examples in the lean is using some visual controls, we can reduce the errors. And errors could be reduced to a large extent if we use visual control. And one more concept called Poka-yoke. Poka-yoke means mistake proofing. Mistake proofing means, Poka-yoke in Japanese means foolproofing. Even a foolish person cannot commit a mistake. So let me give an example. Indented surgical instrument tray. Like if I forget something, I will remember that I've forgotten something, right? A visual hospital is an hospital where people don't have to ask questions to seek directions. It should be visually so nicely displayed that no one has to ask any question. All the answers are visible. Where is the reception? Where is the let's say pediatric department? It's not required. And the concept of Poka-yoke, just to give a little bit of more idea about the concept of Poka-yoke. One good example is rice cooker. Like even by mistake, you cannot burn the rice. So it switches off automatically. If it goes beyond a certain threshold limit, it switches off. Similarly, you can provide this Poka-yoke concepts in many, and it's all visible in smart machines, which cannot be set or operated beyond normal, safe, or maximum levels. So some examples are given here. Abnormal values cannot be entered even by mistake. Even if you want to enter, you cannot enter. This is an example of Poka-yoke. Oxygen cannot be connected to nitrogen because the connections are different. Even if you want to connect, you cannot connect. Again, an example of Poka-yoke. Fixed number of packages during surgery, complete catheter kits for insertion, pre-packed medication cart with correct uses. These are some other examples of Poka-yoke. Just wanted to give you some lean tools which are used in hospital, and of course, which are very much part of your CPHQ syllabus and curriculum. Okay, now let us now come back to where for the topic of the day. So for the next 1 hour, we'll be discussing about some of the fundamentals of data analytics. First of all, do you agree that some data can be measured and some cannot be measured? Do you agree with that? So those who have attended my sessions before, they know the answer, what we are going to say. Do you agree with that? Okay, let me also tell you, there is one rule. Rule number 1 is you can't improve if you cannot measure. Rule number 2, let me ask you a question. Can you measure everything? Can you measure everything? So Chris, you are there. Chris, you are attending. Okay. Wow. I think you have learned by heart all my sessions. Great to see you. Good to see you here. Thank you. So Dr. Surya is telling, okay, you can measure everything, and all of you are right. Yeah. I think I should change my question now. People have started answering this question with yes, always. And you are right. You're right. You cannot improve, you cannot measure, and you can measure everything. Now, let me tell you, how can you measure everything? How can you measure everything? So there are two types of data. Yeah. So when we talk in terms of data, people don't give you the data easily because they are afraid that maybe once they give you the data, you will analyze the data and you'll try to prove some inefficiency or display the inefficiency and project their inefficiency or their inefficiency or in their department to the whole world. So they don't want to give you the data. Or some people say that, well, I have got too much of data, but I don't know what to do with that. And some people say analysis is too complicated. So today, you will understand. If you tell the people why you are asking for the data, they will give you the data. Because most of the time, they don't know why you are asking for the data. So ask the data by telling that you are here to improve the processes. You are here to help them. People will be happy to give you the data. The second part is you don't have to collect too much data. A small sample is good enough to make meaningful conclusion about the population, large populations. And analysis is not at all complicated. There are softwares who can handle your analysis. So you don't have to really worry about it. You should just know that there are softwares, there are experts who can handle all these things. As a CPHQ professional, as a healthcare professional, you don't have to really master the statistical part at all. Unless you want to become a master black belt in Six Sigma, obviously, then you have to master all these things. But even that also is possible, but it takes a little time. Many people I see here, they have attended our green belt and black belt sessions and even master black belt sessions. So they know what I'm talking about. But as a CPHQ professional, you don't have to really go in depth into the statistical parts. You should be able to make meaningful conclusions from the data which is collected in the healthcare. So coming to that, how can you measure everything? So there are two types of data. One is continuous data and another is attribute data. Continuous data has got, continuous data is the data which can be represented on a number line. I'm telling you in the very simple format, although mathematically or statistically, if I start defining, it will be appear to be too complicated, and you really don't have to go into that much of details. So in simple words, there are two types of data: continuous data, also known as variable data. Okay. And then we have got attribute data. Attribute data means what? Anything which can be represented as category. Anything which can be represented as category. So patient waiting time. Patient waiting time. Patient waiting time is continuous data, 30.5 minutes. Patient discharge time, 3.6 hours. These are examples of continuous data. Now, attribute data has got an attribute, and you can measure those attributes first by creating category and then counting how many times and counting how many times that particular category occurs. And you can also convert this into a proportion, or you can also convert this to a percentage. So let us say I want to, let me show you a video. In fact, that, by the way, all these videos are available on our YouTube channel. If you want to subscribe to that YouTube channel, you can get free access to these videos forever. So just click on Anexas Europe, Anexas YouTube channel. Just go to Anexas, subscribe it, and you'll see all the videos, all the descriptions of so many of tools and techniques, which some of them I'm going to talk about.
Hi, I'm Amitabh Saxena.
Talk about today.
There are two types of data, continuous data and attribute data. Continuous data can be represented on a number line. It can have a decimal place. It can also have a unit. Say, for example, age, height. Age is 52.5 years. That's my age. Height, maybe 180.1 centimeters. Cycle time of a process, 3.5 hours. Or procurement time in an organization, 120.3 days. These are all continuous data because they all have a possibility of a decimal, means they can be expressed in decimal points, and also they all have a unit. Now let us talk about attribute data. Attribute data can be expressed in categories, and categories can be counted. Say, for example, if you want to measure happiness, so easiest way to measure any attribute data is to create a category, and if possible you can create a binary category. A presence or absence of that attribute can be one of the simplest categories.
So please remember, whenever you are trying to measure an attribute, always create categories. And the simplest way to create the categories is by looking at the attribute and presence or absence of that attribute. It can be the simplest two categories. Always you will be able to create these two categories for each and every attribute in the world. Not necessarily you have to create only those two categories. You can have 3, 4, 5, like patient satisfaction. You can have high, medium, low. You can have 3 categories. Or you can have highly satisfied, satisfied, neutral, dissatisfied, and highly dissatisfied. You have created 5 categories.
So if I take the example of happiness, 2 categories I can create: happy, unhappy. So if I want to increase the happiness in the employees in the organization, then I can always count how many employees are happy. Let's say 60 employees are happy and 40 employees are unhappy. I can express this as proportion. That means proportion of happy employees in my organization is 0.6 and proportion of unhappy employees is 0.4. And it can also be expressed as percentage. Now this proportion or percentage, they don't have a unit.
So please note down here that in this case, 60 is a count. You cannot have 60.1 people who are happy. So there is no decimal. But in a variable data or the continuous data, the possibility of a decimal was there, and there was a unit like centimeters, kgs, minutes, years, days. These are units. Here there is no unit. It's a count. It's just a count. It can be expressed in one portion. What is the portion of that particular category? So here I would say 0.6. So portion or proportion of happy is 0.6 out of 1. Proportion means portion out of 1. You can also express this as percentage. Percentage means 60% here, 40% here. So total becomes 100%. So these are some exam questions. When I'm dealing with attribute data, how will I express my data? I can express in terms of proportion. I can express in terms of graphs like bar chart or sometimes Pareto chart also. We'll learn all these things. So please understand the percentage doesn't imply that it's a continuous data. For example, infection rate. What do you think? Infection rate is continuous data or attribute data? What do you mean by 2% infection rate? It just means 2 are infected and not infected are 98. So I collected data from 100 patients. 2 were infected, 98 were not infected. It is 0.02, 0.98. Yeah. So infection is actually attribute data, right? Because when I say 2% infection rate, you are actually telling that 2 are infected and 98 are not infected, isn't it? Which is attribute data. Now, it depends on the type of data with which you are dealing, and it will determine what type of graph you should be using to give the information to the senior management. So if you are dealing with continuous data, you will use a histogram. If you are dealing with attribute data, you can use a pie chart or a bar chart.
And a count like 60 employees, I can't have 60.1 employees who are happy. So the count will not have any decimal point. So this is what continuous data and attribute data is. It is very important to know the difference between continuous and attribute data. And it is very important to understand what is continuous data and what is attribute data, because the tools which you are going to use in the measure and analyze phases, they depend on what type of data you are dealing with. If you are dealing with continuous data, then you might use histograms. If you are dealing with attribute data, you may use pie chart or Pareto chart.
And there could be a combination of the data also. One is continuous, another is attribute, or both are continuous, or both are attributes. So in such situations, you will use another types of charts, and briefly, I will talk about them. Okay, let me talk about it. So let's take here example of patient satisfaction. And let me put only 2 categories: satisfied, dissatisfied. Oh, I'm deliberately putting 100 as the total count so that my calculations are easy. It doesn't mean that you have to have 100 counts on. Now, if I want to establish, let's say, is patient waiting time and patient discharge time, anyway, they're too correlated, no point. But yeah, let me take an example. So if I want, first of all, okay, so there are two types, when you collect the data, first you have to display, you have to tell what is the process capability, what is the current process performance. So if I take patient discharge time, let's say, first you make a histogram. Histogram means historical graph. Histogram, historical graph. Means I have got the historical data with me and I have compiled this data in the form of histogram. Maximum, if I talk in terms of patient discharge time in minutes. So I would say that it's let's say 300 minutes. On an average, my patient discharge time in the hospital for patients is 300 minutes. But it is not always 300 minutes. Sometimes it goes to 325, 350, and 375. Histogram. Histogram represents what is the distribution of the data. It also, in a way, tells you what is the central tendency of the data. Here, central tendency is 300. And then it also tells you what is the variation in the data. So here, if I assume the same thing, so although so 225, right? Yeah. So it tells you that the patient discharge time in my hospital is between 225 minutes, which we call it as lower specification limit, and this is upper specification limit, LSL and USL. Now sorry, not specification limits, sorry for that. They are control limits. Lower LCL and UCL, control limits. And the specification limits are given by the customer. Here, the customer could be a senior management. So the control limits are also known as voice of process. Control limits are known as voice of process. My process, like my discharge processing, telling me that I'm going to discharge the patient in my hospital. Patient will get discharged between 225 to 375 minutes. And that's the way we have been operating for the last so many years. So current display of the data reveals that this is my current performance. Are you with me till now? In the exam, a histogram might be given to you and they may ask simple questions out of it. Up to here, you are with me? So control limits are nothing but the extreme values, the probable values of the process. Now let us look at the attribute data. Here I cannot use a histogram, I'll use a chart. Satisfied, dissatisfied, or I can use a pie chart. Satisfied and dissatisfied. Satisfied, dissatisfied. Yeah. So pie chart or a bar chart or a pie chart or a bar chart for attribute data and histogram for the continuous data. And I'm talking about simple tools, right? And when I've collected the data, there will be two important things. One is the central tendency. Central tendency. I think everyone knows about mean, median, mode. If you want, I can explain to you, or what is the significance of that also I can explain to you. Up to you. And variation, it can be measured as range, interquartile range, or standard deviation. So let me, if you want, I can very quickly talk about the central tendency and even the variation. So there are two.
All the numbers,
So mean means
measurement of central tendency and measurement of variation. Some of the common measures of central tendency are mean, median, and mode. Mean means the average of the data. And I'm sure all of us know what an average is. So if you have got a data set, you just add all the numbers together divided by number of samples and you'll get the mean or the average of the data set. For median, you have to arrange the data set in descending order. Median is midpoint of data. Let us see an example of how to calculate median. Suppose someone gives you this data set 7, 11, 13, 9, 3, 1, 4, 5, 6, 7, and 7. To calculate the median, you have to arrange the data in descending or ascending order. So if I arrange the data in, let us say, descending order, it would be 13, 11, 9, 7, 7, 7, 6, 5, 4, 3, and 1. Now I will find the midpoint of the data. So here in this case, I can see that midpoint is 7. So 7 divides the data into two equal parts. So 50% of the data is above 7 and 50% of the data is below 7. So 7 is median. Here my total sample size is 11, so it was easy for me to divide the data into two equal parts. But suppose the data set is even in number. So in that case, what would be the median? The median would be the average of the two midpoints of the data. So if I get, let's say, in my example, there was no 13. So if I divide the data into, again, two equal parts, in that case, then 6 and 7 both would be the median, and average of 6 and 7, that is 6.5, would be the median. And mode is the most frequently occurring data. Here in my data set, the most frequently occurring data is 7. So 7 would be the mode. Mode is usually used for attribute data. So for example, if I'm manufacturing shirts and 60 people say I like a white shirt and 60 people say I like red shirts, so I wouldn't take the average of red and white shirts and start manufacturing pink shirts. So usually for attribute data, we sometimes consider a mode. Another example could be, suppose you have a party and you can serve either coffee or tea, and you have 25 attendees of that party, and 15 people say that I like coffee, and 10 people say I like tea. In this case, mode is coffee, so you would be serving coffee. Mean, median, mode are
So I think that was pretty easy. I hope everyone got through this. Now let us learn what is the measure of variation.
common measures of central tendency. Now let us look at the measures of variation. Variation can be measured as range, interquartile range, and standard deviation. Range is the difference between the maximum value and the minimum value. So in this case, in this data set, the range is 13 minus 1, that is 12. Interquartile range is the difference between third quartile and first quartile. If I go back to the data for which we calculated the median and look at the data.
So if you will see the data here, Let's look at the quartile. What do we mean by quartile? Quartile means I'm tiling the data into quarters. Quarters means 25%, right? So this is the median. Median is dividing the data into two equal parts. And if I divide the lower half into two equal parts, you can see the 4 is the first quartile. This becomes second quartile, and the upper part is third. If I join Q1 and Q3, and Q3, and extend the line to minimum and maximum, this graph is known as box plot. This graph is known as box plot. Okay. So quartiles divides the data into 4 equal parts once you arrange the data in ascending or descending order. So the serial, like the ascending or descending order is important. Then only you can measure your median or quartiles. And the percentile would mean dividing the whole data into 100 parts. That will be the percentile.
The median was 7, but if I divide the lower half into two equal parts, so I can divide it around 4. I can say that is the first quartile, and maybe the third quartile, I can say it's 9. So interquartile range would be 9 minus 4, that would be 5. So quartiles are dividing the data into 4 equal parts. Median is dividing the data into 2 equal parts. If I look at the advantage of median over mean, one of the advantages is that median is not sensitive to outliers. So if there are...
So what do you mean by that? Suppose there was, let us say here, instead of 13, we have 130. Mean will drastically increase. But what happens to median? It is same. So whenever I suspect my data is not normally distributed, and many times it won't be, then in that case, you can always use median. When you have got outliers in the data, and they still, want to be, considered, means instead of like by mistake, this 130 doesn't really appear to be like belonging to this data. Something special has happened on that day. Let's say patient waiting time, 11 minutes, 13 minutes, 9 minutes, but one patient waited for 130 minutes. And he now has is figuring in the sample. So 130 is an outlier. It doesn't, it's not the usual way of our functioning. But if I take mean average, it will drastically increase the mean, but median will not get impacted.
A lot of outliers present in the data, mean might get badly affected and it might give me some vague values, but median would not get affected. So for example, in this case, if instead of 13, the number was 130, the mean would definitely change and it will be a very big number, but the median would remain unaffected. Similarly, the difference between range and interquartile range could be, one of the major difference could be that range is highly sensitive to outliers, but the interquartile range is not affected by the outliers. If the data are normally distributed.
So that was about mean and median, and also range, mean, median, mode, range, and interquartile range. And there's something called standard deviation. Now, standard deviation can be very easily calculated using Excel sheet. In the exam, you are not asked to calculate standard deviation, but you should know the application of the standard deviation. Okay. It's very easy to calculate standard deviation. Nowadays, Excel sheet will give a faster result, or if you are using some software, SAS or Minitab, etc., you can quickly do that. But application of standard deviation is what is more important to understand. First, let us understand. By the way, do you really want to know the? Anyway, it will take more time to tell you how to calculate standard deviation. Just trust me, it's very easy. Just put the data into Excel sheet and down below press is equal to STDEV. You'll get the standard deviation. But importance of standard deviation is something which you should understand. Mr. Gauss in 17. By the way, if you are interested in learning the formula and the calculation of standard deviation and even derivation, I have even derived the standard deviation. It's given in this link, which is now present in your chat box. You can copy these links. I'm giving you some really good links. Copy. You can just study those topics at a later stage whenever you are free. So this link gives you all the explanation of what is standard deviation and what is the derivation from where you're getting the standard deviation. That is also given there. Feel free to go through that. But now let us, as told you, let us focus on what is relevant to. In the CPHQ, they will never ask you to calculate standard deviation, but you should be knowing the application of standard deviation. So let us see a theorem called, let's talk about the theorem called Gaussian theorem. Mr. Gauss, he studied the repetitive processes multiple times, anything which gets repeated. He said that most of the time it will have, it will always appear that there is a central tendency. Central tendency means the mean or the average of that data set. Plus, you will have a little bit of variation, which can be easily determined using a simple formula or just feeding the data into the Excel sheet and I can get it. He said that around X bar means around the sample average plus 3 times the standard deviation and minus 3 times the standard deviation will lie 99% of the total population, 99.73 or 99% of the total population. I'm not talking about the sample, I'm talking about the population. Let us take an example. I am going to the hospital every day from my office, from my home to maybe hospital, and I collect the data of my travel times. One day I took 30 minutes, another day I took 35 minutes, another day I took 25 minutes, 28 minutes, 26 minutes, 36 minutes, etc. Now it will have an average. It will have a standard deviation. Let's say the standard deviation is 5. So looking at the Gaussian theorem, and I hope everyone is fine if I have given you the link to where I have talked about standard deviation in detail. I hope that's fine with you. I'm not explaining this here in the session. I'm expecting you to see that video. Yeah. But I'm more emphasizing on the part which is usually asked in a CPHQ examination, and they expect you to understand the concepts, and that's what will be tested. So coming back, our X bar is 30 minutes and standard deviation is 5 minutes. Going by the Gaussian theorem, This is average, 30 minutes. Going by the Gaussian theorem, this is plus how many times? So 30 minutes, 1 time standard deviation, 2 times standard deviation, and 3 times standard deviation. 1 time standard deviation will be how much? 35. 2 times standard deviation will be how much? 40. And 3 times standard deviation will be 45. Similarly, here also on the left side, 30 minus 5 is 25. 25 minus 5 is 20. And 20 minus 5 is 15. So I can say that my process, or my here, let's say traveling time, is fluctuating between 15 minutes to 45 minutes. Without even going to the, without even collecting the all data of my all travels, which is not required. I'm just collecting few samples, 30 samples, 40 samples, and I'm predicting about all of my travels. As long as, of course, I go to the same office, almost in the same vehicle, etc. So this is how one of the powers of histogram is using a small sample, 30, 40 samples, you can estimate the probability distribution curve. Probability distribution curve. So if I extend the Gaussian theorem to this, saying that all the repetitive processes, they follow normal distribution. Why it is known as normal distribution? Because it is normal to obtain a normal distribution. Okay, it's normal to obtain a normal distribution. 1 sigma, 2 sigma, 3 sigma, minus 1 sigma, minus 2 sigma, minus 3 sigma. So this is 30 minutes, average is 30 minutes. Standard deviation is 5 minutes. So this becomes 35, this becomes 40, and this becomes 45. This becomes 25, this becomes 20, and this. This we will call plus and minus 3 times standard deviation will be called as lower control limit and upper control. Please remember, control limit is different from the specification limit. Control limit is not the same as specification limit. Specification is given by the customers, and control limits are given by the process. Okay. Control limits are given by the process. It is determined by the process by collecting the data about the process. I hope you are with me. And then there is, of course, a customer specification limit that if you are taking more than 35 minutes, this is known as specification. Specification limit, specified by the customer. Anything going beyond the specification limit becomes a defect. And you can easily estimate the probability of getting a defect using these normal distribution curves. I teach all these things in black belt, so right now I won't go into the too much of details about this particular chart, but I hope you understood the essence of it. Now, let's for the time being forget about the specification limit. Just look at the control limits. If I plot these control limits, lower control limit is 15 and upper control limit is 45. So typically the process will behave like this. Mr. Gauss also told that in fact, later on, Mr. Shewart he had wide applications of all this, whatever we are learning right now in the industry, in the organizations. And he said that this will be known as natural variation. Natural variation is this is how our process naturally behaves. Like if I go back to my previous example of going to the office, if someone asks me one day you are taking 40 minutes, another day you are taking 35 minutes, why? If I search for answers, it is waste of time. What is the right answer? The right answer is between 15 minutes to 45 minutes is the natural variation of my traveling process. So expect me 99% of the time within this range. But if still you find me taking more time, like say, for example, it may happen that one fine day, it took 90 minutes. Then you should investigate that, you should find the root cause. It doesn't mean you have to do root cause analysis every time, or you have to do only for outliers. It could be for outliers as well. It could be for, to improve the process also. So here, if let's say, okay, let me show you the video. In fact, it will help you to understand better. With the video, there are visuals, it's very easy to show you.
So if you want to change, if you want to make changes, go ahead with it. And your data collection plan should be such that it should be able to gather data about both X factors and the Y factors. Once you have collected the data, then it's time to display the data. We also use descriptive statistics here. So you can use a histogram, you can make a control chart, you can display the data collected as run charts, etc. To give you a little bit idea of what is control chart, let us take a simple example. Suppose I collect the data of my travel time from my home to office every day, and I find that on an average I'm taking 30 minutes and standard deviation is 5 minutes, and we know how to calculate the standard deviation and how to calculate the average. Now if I plot the data on a histogram, then lower control limit would be -3 sigma limits, that will be 15 minutes, and upper control limit would be 45 minutes, that is plus 3 times the standard deviation. So lower control limit being 15 and upper control limit being 45, I can say that my travel time is going to vary between 15 to 45 minutes. So you can expect me to travel to my office every day between 15 to 45 minutes. If someone asks me why this variation between 15 to 45 minutes is there, I can tell him that it is due to common cause variation. What is common cause variation? I can say that the variation between 15 to 45 minutes is due to lots of factors. These factors can be the traffic on the road, the weather, the car I use, my mood, or it can also depend on at what time I start from my home. So a lot of factors, which we can call it as X factors, are affecting the travel time, which is the Y here. So I can make the statement that the variation between 15 minutes to 45 minutes is due to the common causes. Means all the causes are acting on my system and producing this variation. This is known as voice of process, as if my process is telling, my traveling process is telling that I will take between 15 minutes to 45 minutes. Now, if I take 60 minutes to travel to my office, then same question is asked to me, that why did I take 60 minutes? Then my answer won't be that all the causes are acting on my system and producing this variation of 60 minutes. I might be able to point out a cause. We call it a special cause. So I may say that I took 60 minutes because maybe today there was too much traffic on the road, or it can be any factor. So when I go out of control limits, I can specify a special cause. And we call this variation as a special cause variation. So we have two types of variation: common cause variation and special cause variation. Common cause variation is part of the process, part of the natural variation of the process. And special cause variation is assignable variation. I can assign a cause to that particular event. Now, what is the difference between common causes and special causes? For special causes, you need to take immediate action. Means you need to take a prompt action so that you are able to bring the process within control. But for common causes, you should not take any specific action. Usually, the common cause is within the control limits, and if you want to act upon the common causes, you might have to change the control limits, and changing the control limits takes effort. You may have to do a DMAC project. You may have to do a lean project. You may have to do a Six Sigma project. And that's what we are doing. That is why we say that lean and Six Sigma is applied to chronic problems. A process is behaving in a certain way. It is behaving within some control limits for a long, long time. Last 6 months or 7 months, your procurement time has been, say, 120 days plus minus 30 days. And I would like to change the control limit. I would like to change the DNA of my process. And that is why I would need to do a Six Sigma project.
So that was a very brief overview, using a simple example. Now, the same thing can be applied to the waiting time. Same thing would be applied to your infection rates or length of stay. The application of histogram and a control chart. Let me ask you one question. Are you able to any questions? Do you have any questions? Okay, so I think I see that everyone has understood this. That's great. Okay. So the process under control doesn't mean that it's a good process. Process under control doesn't mean that the customer is happy. Process under control just means that it is predictable, it is stable. Yeah. And anything within the control limits, I should not search for reasons. Okay. So the data analytics module is almost similar, yes. Similar to what inequality related tools and techniques are, right? Okay, great. Now we have to improve, right? So let me show you an example, or let me, although this Minitab is not part of the syllabus of CPHQ, but I will just to show you the applications of tools and techniques. When you want to do a root cause analysis, suppose you want to reduce the patient discharge time in your hospital. Yeah. You want to do a root cause analysis. So you can always do a cause and effect diagram. Cause and effect diagram, causes, and you have got effect. Causes could be for your delayed discharge time of the patient. You can brainstorm on the causes like man, machine, material, method, measurement, or people, you can say environment. And environment, just to make it M, you can also write Mother Nature. Man, machine, material, method, measurement, and environment. So you brainstorm on these under these categories, try to collect as many causes as possible. And this is known as cause and effect diagram. You can further filter them down to some manageable numbers. So manageable numbers in the sense, like if I take example of here, I have got one example. Just to speed up my the explanation part, I'm just using one software called Minitab, which analyzes the data quickly. In the exam, you don't have to do any calculations. You should understand the applications, like you should know what's the histogram, what is a control chart, and that's good enough. So let's say this is patient discharge time listed here. Very easily, either using Excel sheet or using Minitab, you can create your histogram. So this is how your discharge time looks like today. Average is 300 minutes, standard deviation is 25 minutes. And median is also given, first quartile is also given, minimum, third quartile, maximum, etc. is given. We can also create a control chart. Control chart is it calculates by itself average. Average is 303 minutes. Standard deviation is something around 25, 26. And 3 times standard deviation and low, 3 times minus and plus standard deviations. You can create your control limits, and you can make a statement that the patients are being discharged between 227 minutes to 379 minutes. So one patient may get discharged at 360 minutes. Another patient may be getting discharged at 260 minutes. Don't try to search for the reason why. It could be multiple causes. They are all acting on the system and producing this variation. It's a natural variation. This is how a process works here in our hospital. Obviously, we are not so happy with these kinds of delays. So then we take up an improvement projects. And here in man, machine, material, method, measurement, etc., we have brainstormed on the different causes, which is actually impacting our patient discharge time. And we can create a cause and effect diagram. So this is the cause and effect diagram. Now we are doing the root cause analysis. Which cause is occurring more often? We can apply Pareto. Vilfredo Pareto was an Italian economist who found that 80% of the money or the wealth was with 20% of the people in his country. 80% of the money was with 20% of the people. So he applied this to various other areas, and he found, surprisingly, this 80-20 rule was really applicable almost everywhere. So Joseph Juran, he adapted this in quality, and he said that 80% of the problems, 80% of whatever problem you are facing is due to 20% of the causes. So if you have listed down, let's say 10 causes here, only 20% of 10, that means two causes will be responsible for 80% of your delayed discharge times. Which are these? So they collected the data and they have noted down the causes. Every time whenever there is a delay, they assign a cause to it. And some of the causes, they appear many times, many more times. So you can create a Pareto chart out of it. Pareto chart manually also could be created. So when you are looking at okay, just let me know, just say yes or no. Are you aware of Pareto chart and how to make it? Just write yes or no. If you are already aware of, I can skip that part. Say no, then okay, no problems. I think many of you are telling no. Okay, so let me talk about this. No issues. So first, I will write the causes and the frequency. Causes and the frequency means these are the causes and how many times each cause is appearing. Yeah. Okay, let me show you one. I think the video helps a lot. If I
Once we have naturally, the variables which are controllable and have high impact, 80% of the. Another way to narrow down on the root causes is Pareto analysis. Vilfredo Pareto was an Italian economist who found that 80% of the wealth was with 20% of the people in Italy. And Joseph Juran, he borrowed this principle, the 80-20 principle from Pareto, and he applied to quality, and he said that 80% of your problems are due to the 20% of the causes. So if you have listed down 10 causes, 20% of those 10 causes, that means 2 causes, are responsible for 80% of your problem. Let us take an example how to apply Pareto to our procurement cycle time case study. Let us imagine that we have listed down 5 causes. I'm just taking 5 causes as an example. In fact, the causes can be 6, 7, or 10, or 12 also. So if the 5 causes which I've listed down are, let's say, late deliveries is one of the causes of procurement delays. Then specifications are not clear. That's also another cause. Maybe the delayed approvals are found to be one of the causes, and then the delayed vendor selection and the customs delay. If I collect the data on delayed procurements, and let's say I collect the data on 50 delayed procurements, I find that 25 of them are due to the delayed deliveries, 15 of them are due to the specifications lack of clarity, and 3 of them are due to the delayed approvals, and 6 of them are due to the delayed vendor selection. And customs delay is responsible for 1 delay in procurement. So in this case, I will list down all of these frequencies against the causes, and after that I will rearrange the causes in the descending order of the frequency. So here it would be late deliveries 25, specifications not clear 15, delayed vendor selection 6, delayed approval 3, and customs delay 1. After that, I will calculate the percentage contribution of each of the causes. So in this case, delayed deliveries are contributing to 50% of the total causes, and specifications not clear is contributing to 30%. Then we have delayed vendor selection contributing 12%, and delayed approval as 6%, and customs delay as 2%. In the next column, I will write down the cumulative frequencies. So cumulative frequencies would be late delivery, the first one contributes to 50%. First 2, that is late deliveries and specifications not clear, contribute to 80%. And then the first 3 contributes to 92%, and so on and so forth. And after that, once I have made this table, I will create a graph which will arrange all the causes in the descending order, a bar chart, which will indicate the causes in the descending order. And also it will tell the cumulative frequency as well. So from the graph, I can easily see that 80% of the delays are due to delayed deliveries and specifications not clear. So these are the two root causes which are contributing to the 80% of my total procurement delays. This was just an example. Obviously, you will have many causes and you can put this into Minitab and you
Just to show you, like it's so easy nowadays in Excel sheet or Minitab, you can easily, uh, you know, get your Pareto chart. So I'm just trying to make the Pareto chart on the given data. And it tells me that reporting not accurate or reports not accurate, some inaccuracy in the report that causes the delay. To rectify that report. 27 times it happened and contribution percentage was 29.7%. Similarly, staff not available, 23 times it happened and it contributes to 25%. The total first two are contributing to around 54%. So you can say if the first four are contributing to almost 75 or 76%, and I can focus, these become my root cause. Now they can be further validated, but some of you are asking about, okay, let me ask you one more thing. And I can, we have got many, see, in fact, there are 7 modules. I just talked about one module today. Even not in one module, I just talked about a bit of that module. But are you interested in joining the CPHQ training, the full-fledged CPHQ training? If you are, just you can answer these questions. And depending on your answer, I'll also send you some information and the linkages and links so that you can, further upgrade yourself. So I just request everyone to participate in the poll if you are interested in learning the CPHQ, and that will help me to plan some of the for future trainings. And yeah, so I hope everyone has answered this question. Okay, great. So I see that almost all of you are interested in the CPHQ training, most of you immediately, and some people are telling even they will attend later on. So thanks a lot. That is helpful, actually, helpful information to us. And we'll definitely send it to you, the details of our next training programs. But we have not yet finished, by the way, right? We have, please remember, I have to complete the improve phase also. Are you planning to appear for CPHQ exam anytime in the future? Okay, so most of you are interested in appearing for the exam. Okay, great. Okay. Okay, so this reducing patient waiting time I was just talking about, but let me show you a full-fledged project. Let me show you a project, a typical project, process improvement project. This is a project following Six Sigma approach, DMAG. In Six Sigma, we follow define, measure, analyze, improve, and control. These are the 5 phases in any project, improvement project. The define phase, you write the problem statement, and here the problem statement is that it is taking, patients are taking 93 minutes for the waiting. And you would like to reduce this 90 minutes to 30 minutes. Then you can look at the project timelines, define, measure, analyze, improve, control. Because in Six Sigma, we are following these 5 phases. And we also make, if you remember, I showed you a systems map. In the beginning, I showed you the systems map. So just pull out supplier, S for supplier, I for inputs, P for process, O for outputs, and C for customers. SIPOC. So to get the information about the whole process and to have a process approach, because problems are not in the people, problems are in the processes. So whenever you have a problem, whenever you want to solve something or solve a problem in your hospital, or you have to improve something in the hospital, first you know a SIPOC of that process. Donabedian, he called this as this is outcome, in process, and structures. So you have outcome measures, process measures, and structural measures. Yeah. Then we collect the data and we do a histogram of our waiting time. And then we identify the reasons of our waiting time. And once we have identified the reasons, we do a Pareto on those reasons. We get the root causes, and then we implement some solutions on the root causes by doing some brainstorming. Now, when you are doing a brainstorming technique, you have to follow certain rules. I'll tell you about the rules as well. But before that, yeah, so this, once you improve the process, you should be able to sustain the gains. It should not happen that, you have reduced the waiting time, but after some time it goes back. So if you reduce, see here, the waiting time was somewhere here. Now you have reduced. It should not go back again, back to the original state. So it should be able to sustain that gain. So we ensure that we have system in place, we have SOPs, training in place, so that people don't go back to original habits. So this is a typical DMAC project I just wanted to show you. So there are many projects which we give to our students, and also we give you lots of questions, mock questions. We have got a lot of mock exams on our learning management side, but of course that part is paid part, so you have to pay for that in case you are interested. Also, one more thing, FMEA, failure modes and effects analysis, is one very good tool which you can use it to solve any problem, any pressing problem in your hospital or clinic or the lab. If you are interested in learning about FMEA, I'm giving you a link. Please click on that link and watch that link in full. It's around 20 minutes. It also gives you not only the information of how to do an FMEA using a simple example, it also tells you how to make an FMEA using it in the Excel sheet. The template is also given to you. So that link is provided in your chat box. So feel free to watch that video. And as I told you in the beginning, Mr. Andrew Robertson, these trainings in worldwide. We have ministers of Ministry of Health from 3-4 countries, and many hospitals, many doctors, many nurses, many lab professionals. They have attended our training programs, and we would like to invite you to attend our training programs. We have got earlier, the fees was quite high, but now you are going to get the CHQE certificate for free. So CPHQ preparation training for first 10 registrations is less than $300, less than I'm talking about. Discounted price after 10 registrations will be $300. But how much it would be less, it depends on how soon you register. So first few are very, very less. And as we proceed, it goes up to $300 for first 10 registrations. In your local currency, how much it is, we'll be happy to tell you. And if you complete green belt, black belt from us, plus CPHQ, you can also get a TQM diploma. So, most welcome to join. And if you are joining today, then you can you can attend our sessions any number of times in the future, till the time you get the confidence of appearing for the exam. In fact, attending the session is just 50%. 50% is self-study. And we also tell you, we give you a material which is comprehensive, and that's good enough for you to study. So anyone who's interested, please click on the link below and you will get all the information. We also do other free workshops like Yellow Belt training. Okay, the dates, if you can show, I think these dates are older dates. Can you show the dates? So these are the next weekend batch. We are starting on May 20th. If you don't have time to join on May 20th, then you can join on June 17th. So May 20th or June 17th, you can join both batches also. Once you join any batch, you will get access for free for all the other batches. Okay. So feel free to join us. Feel free to learn more and more about quality in healthcare domain, and you can also improve your career. All our examples are practical. Due to the less time, of course, 2 hours, we did not cover too many topics. But if you want to hear about other topics also, we have Anexas YouTube channel. Click on that and get information. These are the different days of training, and we always not only conduct the theory, but also give practical examples in the classroom. And there is a new format of exam from March onwards. So we are following the new format. So whatever you are showing, whatever you are seeing here, the 7 modules, they are coming from new format. So around 2 months back, they changed the format and we are perfectly aligned to the new format. These are the training times on Saturdays. And these are the free webinars which we keep conducting. If you are interested, you can most welcome, you can join us. Okay, thanks a lot. Everyone, you can just watch some videos related to CPHQ as I leave you. And if there are any questions, I'll also be happy to answer these questions. Thank you. Hi everyone. This video might be of interest to those who want to get